Good. We're gonna get started. If you would like to have a seat, we'll go ahead and start it with our program today. Welcome. My name is Marina Rabinovich. I'm the president-elect for the Southeast chapter. Just to let you know, our mission is to secure the highest quality care for all critically ill and injured patients through a multidisciplinary approach. And we really appreciate you being here with us, as well as our people who join in through a live webinar, including our remote site in Memphis, who is joining us through the live webinar as well. Just a few chapter updates before we go ahead with our presentation for today. If you are receiving CE or CME for today's presentation, make sure you fill out all the necessary information like the sign-in and the evaluation forms and submit them after the meeting. I'd like to thank you, our supporters, the Cubist and Jensen, for supporting our chapter and being here with us. If you visited their table and had your card punched, make sure you submit that as well. There's going to be a raffle at the end for a prize. So if you'd like to participate, make sure you submit that. We will have our business meeting, our annual business meeting at the SCCM National Conference in Phoenix, Arizona on January 19th. So I hope you can join us there, and we'll talk about what we've done in the past and our plans for the next meeting. Just to let you know, we're proud to sponsor a fundamental and critical care support course for non-critically ill not critical intensivist practitioners who would like to learn how to take care of critically ill and injured patients in the first 24 hours, and we will be providing this course on April 4th. But there will be way more details coming your way about this. And one more thing, if you are interested in publishing, feel free to publish with us in our triannual newsletter. And one is to be coming out soon, so we hope to get some submissions from our members. Those are the chapter updates, and at this point, it's with great pleasure that I welcome Dr. Michael Connor, who's our keynote speaker today, and he will be speaking about fluid resuscitation management in critically ill patients. Dr. Connor is an assistant professor at Emory University and is dual trained in nephrology and critical care medicine, sharing his clinical duties between critical care medicine and inpatient consultative nephrology. Dr. Connor specializes in acute kidney injury and delivery of extracorporeal blood purification treatments in intensive care unit environment, and the complex challenges presented by critically ill patient population. His research interests have centered on the pharmacokinetic properties of antimicrobials in patients on CRRT. Please give a warm welcome to Dr. Michael Connor.
Well, thank you, Marina and Dr. Chester, for the invitation. Prasad, do we want to start this, or are you showing things already? Good. All right. Well, thank you so much for the invitation. I hope everybody can hear me. I want to make sure I'm not talking too loud for the recorded stuff. We're going to talk about fluid management and critical illness. There's a couple of things that I think we need to start thinking about moving beyond, which is saline and potentially this idea that our patients should swell and that's okay. As far as objectives go today, let me see if I can get my pointer working. Not sure it is. Hold on. Okay, so I want to make sure that you guys are able to describe the differences of various isotonic fluids. I want you to understand the recent studies comparing these, as well as understanding the association between hypervolemia and outcomes in the critically ill, as well as volume management in the critically ill patients. So we're going to go through several different topics. The talk is largely divided into two halves. The first half we're going to be talking about various isotonic fluids, and the second half is we're going to talk about how we use those. Couple of disclosures. I don't have any conflicts of interest that pertain to this topic. However, I do want to say that the opinions and debates about this have been raging for decades, and that data might be starting to challenge some very long-held dogmas and assumptions. So I will be more than happy to field your questions, your insults, your rotten tomatoes, and arrows as we get towards the end of this. But in the meantime, I hope that maybe I'm going to tell you a story that starts to change your clinical practice. I'll tell you up front that I used to have a very different clinical practice as it pertains to these topics that I do now, and we'll come back to that discussion at the end. So as a case goes here, why my slide? There we go. We should always start with a case. So a 57-year-old male comes in with acute abdominal pain, found to have a perforated viscus, and undergoes an emergent exploratory laparotomy and a right hemicolectomy. During that procedure, his urine output was very low, and on arrival from the operating room, our anesthesia colleagues kindly delivered him with a blood pressure of 72/35 and a heart rate of 110, and he was intubated and sedated. What sort of things do we need right now for this patient for acute resuscitation? Anybody think we need pressors? Anybody think we need fluids? I see a lot of heads nodding up and down, but I saw most people saying no on pressors. We'll see how that changes over time. Are you worried about the renal function in this patient? Can you do anything about it at this point or not? So you shouldn't beat yourself up if this patient ends up with bad acute kidney injury, because the horse might have already left the barn on this one, but we'll see. There's a few things that we can do that might help that. Okay, so let's talk about volume expansion. I just want to, I know that this group is very intelligent, but I just want to make sure, for some reason this thing keeps on not allowing me to advance my slides. Okay, so volume expansion is recommended in volume depleted states. Now, the advanced practitioners and physicians in here will certainly admit to the fact that we don't always know how to tell if someone's in a volume depleted state. There's a few things we can use, like very low CVP or passive leg raise or stroke volume variability, that can be helpful, but it's a very challenging thing sometimes to understand when someone's in a volume depleted state, harder than you would think. And controlled volume expansion in the acute resuscitative phase of shock is highly recommended. Now, the optimal targets for fluid resuscitation are still very unclear, but there are some studies that sort of suggest we need to have a CVP of greater than 8. Now, that's not normal, right? Most of us sitting here right now have a CVP of 0 to 4, but a CVP of 8 and a MAP greater than 65. More importantly, we should really, once we reach these targets, we probably need to think very closely about whether or not we should expand them further beyond what we're seeing. But we should make those decisions only if there's sort of clear hemodynamic benefits to further volume expansion. And obviously, we all know that there are two purposes of fluids, okay? The first is to give bolus volume expansion. And this is what we do most commonly when these patients come out of the operating room. And it's really done with isotonic crystalloids or colloids. That's still an ongoing debate, believe it or not. And it really should be rapid administration to correct symptomatic volume depletion. And by its nature, this should be limited and discrete. This is in contrary to maintenance IV fluids, which can be isotonic or hypotonic crystalloids. We never really use colloids for maintenance fluids outside of the burn ICU, where they sometimes use FFP for reasons that we won't go into. And these really should be targeted fluids in high-risk patients. In other words, people who have high ongoing and or predictable losses, okay? So that patient who you have relieved their urinary obstruction and they're making tons and tons of urine might need some sort of hypotonic maintenance IV fluids. But all too often, I would argue that this is indiscriminate and way too much, okay? I'm not going to let you get out of here without a quick review of acute kidney injury, which seems a little bit off topic, but because we're talking about side effects of volume expansion, one of the things we're going to talk about is acute kidney injury. So I just want to make sure we're all on the same page. Acute renal failure is now called acute kidney injury. To keep us all in business, we have to reinvent the diagnoses every so often. Okay, so there's two different criteria, and they're basically the same. The first is something you hear called rifle criteria, which stands for risk, injury, failure, loss, or ESRD, which generally you'll never reach in the ICU because you have to be 4 weeks or permanent, which most people aren't in the ICU that long. But if you have an increase in your creatinine of 1.5 times above your baseline, so if your baseline is 1 and you go to 1.5, you meet criteria for risk, injury, and failure you can see here. There is some urine output criteria, although these are not very well validated. These you'll see can predict mortality, but urine output criteria don't really seem to predict mortality very well. And we sort of have coalesced into something called the AKIN criteria, acute kidney injury network criteria, which has sort of taken lots of different published studies on all of this and sort of merged it all into one criteria. And in this one, I do want to point out that this criteria you meet if you go up by 0.3 above your baseline. So if your baseline is 0.7 and you go up to 1, or you go from 1 to 1.3, you meet AKIN stage 1. Now, why is this important? Because we know that survival in the ICU clearly correlates with the peak severity of your acute kidney injury. So the more severe your acute kidney injury, the more likely you are not to survive in the ICU. And this has been shown in many, many studies. So in each of these bars, they're comparing different levels of acute kidney injury. So this is risk versus no acute kidney injury. This is injury versus no acute kidney injury. And this is failure versus no acute kidney injury. And you can see that in all sorts of different ICUs, as you increase in the severity of acute kidney injury, your risk of death during that hospitalization goes way up. Okay? So this is to the point that it can be up to 10 times higher risk of death. So this is important information, and I just want you to bear this in mind as we talk about some of these next things. Okay, now getting into the meat of our discussion about IV crystalloids, let's talk first about IV fluids. They're the most common drug that we use in the ICU. In 2013, Emory Healthcare purchased 212,856 liters of normal saline. Now, I can't break this out for you as far as where these were given or wasted, but in this situation, you can imagine that a large majority of these are probably given in the intensive care units, in the emergency departments, and to some degree the operating rooms. We had a lot less purchase of LR and plasma light, but those are changing and evolving. Why do I call it a drug? There's a lot of pharmacists in the room who probably agree with me on this, or I hope they do, but there's a proper and correct fluid for whatever you're trying to do. Just like if you're treating a certain pneumonia, there's a proper and correct drug. There's a proper dose, and in this situation, an amount, okay? We have, it's either 500 cc's or 4 liters. There's going to be a difference in outcome based on if you've given them the right dose. And there's a proper timing of administration, or in other words, a rate or frequency. How often are we going to do this? Are we going to continue it? Is it going to be a continuous infusion? Is it not? So I think that there's lots of properties of IV fluids which easily make them fall into the category of what we call drugs. We oftentimes don't think of it about that way. Okay, so when we're doing fluid management, there's been an increasing description of trying to view fluid management in the critically ill in 4 phases. You first have your rescue phase, where the patient comes right into the emergency department or right in from the operating room, like the patient in our case, and we have to give them a lot of fluid to rescue them. Then we spend several, and this is over the course of just a few minutes to hours, then we spend several hours sort of optimizing them where they might not get a lot more fluid. Then they're sort of stabilized, and this period of stabilization can be either short or really, really long. Like they might be stuck on pressors for several days, but just sort of otherwise doing okay. So that stabilization could be a really long period, and then eventually, hopefully that they're going to get better and we can take some of this fluid away, okay? Now, this model, I think all too often goes up like this and then just sort of continues upwards like this, okay? Furthermore, this model, I think, is useful for thinking about critical illness in general, okay? As if you want to change the y-axis to some sort of idea about severity of illness or complexity of interactions or interventions, we're doing lots of we rapidly increase the complexity of the patient. Then things sort of level off for several days where the patients are on the ventilator, on pressors, we're sort of feeding and they're sort of getting antibiotics and they're doing better. And then eventually, we hope that they're going to sort of recover. Other times, they sort of just continue to get worse and then they die, right? Okay. Keep this picture in mind as we go. We're going to come back to this later in the talk. So what IV fluid do you want to use? That's our good old friend normal saline right there. So colloids and crystalloids. I'm going to just have one slide on this because this is not the purpose of this talk. And I think for the most part, we have yet to have any data that shows a demonstrable difference in mortality between colloid or crystalloid resuscitation. Now, I'm certainly aware that certain blunt trauma injuries with hemorrhagic shock, obviously we need colloid resuscitation, usually with massive transfusions and a 1-to-1 ratio of PRBCs to FFP. But just in general critical illness, in all sorts of different settings, post-surgery, sepsis, other sorts of stuff, we've yet to find a difference. There was a Cochrane database review in 2013 that showed no difference. The SAFE trial is well known to all of you. You can't be more on top of each other in terms of outcomes between saline and albumin. And there was a lot of spin-offs of this trial because there was some subgroup analyses which suggested that septic patients might benefit from albumin. And one of them was published earlier this year. I think it's called the Albios trial, which again was a negative trial of albumin in the use of sepsis. Okay? There is one thing. Hydroxyethyl starches we have basically found to be nephrotoxic and a higher rate of dialysis, and I have rarely seen a drug fall off of use as fast as hydroxyethyl starches have. Basically, they went from being used quite frequently in the operating rooms to basically being used almost never over the course of like 12 months. And for good reason. We're not going to get into this, but it's pretty strong data that they're nephrotoxic. Okay. So let's talk about 3 cases. These are 3 people that I saw here at Grady earlier this year. The first was all in 1 week. The first was a 40-year-old male with severe septic shock in the emergency department, hypotensive with these labs. The second was a 48-year-old female with abdominal pain and vomiting for 1 week, also hypotensive, and she had these labs. I'm assuming everyone knows what these are, right? Sodium, potassium, chloride, bicarb, BUN, creatinine, glucose, right? Everyone's okay with that? Okay. And then the third was a 76-year-old female nursing home resident who came in hypotensive with altered mental status and had these labs. So clearly, these patients are all similar in that they're hypotensive. They're all probably going to need some sort of volume resuscitation, but their labs are vastly different, right? Can we really use the same drug to treat every one of these patients? No, even though we're very married to vancomycin, it doesn't mean it's the right drug that we should be picking for every patient who comes in with a concern for infection. Similarly, we can't be thinking that every IV fluid is the same. Okay, let's talk about isotonic IV fluids. So, I'm not going to talk about any of these hypotonic, half-normal saline stuff, which I don't believe in anyway. But anyway, isotonic crystalloid solutions. This is our good favorite normal saline, right? Everyone knows this. Surprisingly, most people don't realize it has a pH of 5.4. So you're basically infusing your patient with acid, okay? And the osmolarity, we know that it's hyperchloremic, and I want to make it clear that this falls into a category of what we call hyperchloremic solutions. And this is sodium bicarbonate, and this is if you make it the way that I think that it should basically only be made, which is isotonic sodium bicarbonate, which is 3 amps of sodium bicarbonate a liter. Depending on how you mix it, the osmolarity is going to be sort of around 300, or whether or not there's dextrose in there, and the pH is around 8. Okay? Now, there are several other fluids. One that you guys are quite familiar with is called lactated ringers. It's got a little bit of everything in it, and we call these next groups balanced crystalloids because they look a lot more like your serum looks on a daily basis. They're a lot more balanced across the way. It's got a lot of lactate in it, and this lactate will be converted to bicarbonate if your liver is working. The pH is a little bit better. There's not nearly as much chloride. This is in contrast to something called plasmolite A, which has a little bit less chloride, does not have calcium, so you don't run into some of the medication interaction issues, has magnesium in it, does not have lactate, so you don't have to run into the situation of wondering if my lactic acid is related to too much LR administration. It has acetate and gluconate, which gets converted to bicarbonate by the liver, and the pH is 7.4. There's also something that's not really available in the US called Hartmann's solution. It looks a lot of it like LR. And to be complete, there's actually something called plasmolite 148, which you have to be very careful with when you are thinking about this if you're going to have this at your hospital. The only difference between plasmolite 148 and plasmolite A is the pH. So the pHs are corrected in this one using sodium hydroxide, and in this one the pHs are brought down to 5.5 by using a little bit of hydrochloric acid in it to change the pH. So when we talk about the studies coming up, there's going to be different studies that have looked at plasmolite 148 and plasmolite A. And for all intents and purposes, in a lot of these trials, they're sort of interchangeable. except that the pHs are different. So you're going to expect a different response from sort of an acid-base status when you infuse them in patients. OK, so let's move on. So 0.9% abnormal saline versus balanced crystalloids has been debated for decades. I will tell you, where I trained, the surgeons used LR. The medicine folks like me, we use normal saline. And we both thought each other were crazy for many reasons. But it's been going on forever. The question is, are there any beneficial effects of one or the other? And we know that rapid expansion of normal saline does cause hyperchloremia. How many people have seen that? Pretty much everybody, right? OK. The question is, are there any detrimental effects to that? So you get this expansion metabolic acidosis. I'm going to talk about some data that says that that might actually exacerbate hypotension, which is not really what we want. There are potentially some renal or other end organ effects. And there is some data that says that you get more edema formation when you use hyperchloremic solutions compared to balanced crystalloids. So I'm going to go through two trials that I want to take a little bit of time to explain. And I want to be very clear on these as to what they're looking at so that we don't have any confusion. These two trials we talked about were done by the same group, but separated in time by like 6 or 8 years. And they took healthy people, in this case, healthy adult males, OK? Pretty young, like in their 20s. And they gave them 2 liters of one IV fluid and measured all sorts of stuff. And then they brought them back 7-10 days later and gave them 2 liters of another IV fluid and measured all the same stuff again, OK? So these are healthy people. What they're looking for here is what is the normal response in euvolemic individuals to volume expansion. If you go and drink Gatorade, you drink a 32-ounce Gatorade, it's generally not a good idea to suddenly get in your car and drive for like 8 hours, because you're going to have to pull off the highway. Most of us are going to have to pull off the highway in about 60 to 90 minutes to start urinating all that Gatorade off, OK? So what we're looking for here is if we give somebody a bunch of fluids, is how does their body respond normally to this? So you can see here that when they gave people these 2 liters of fluid, their sodium levels came down a little bit. The LR comes down more because it's only, the Hartman came down more because it only has a sodium concentration of 130. You can see that their serum chloride level really went up when they got to 2 liters of normal saline. And you can see here that the measure of their acid-base status, called strong ion difference, they became more acidemic with the normal saline expansion. And everybody's weight went up 2 kilos because it weighs 2 kilos to give them 2 liters of fluid. But the normal saline group had a harder time or a slower time returning to baseline compared to the Hartman's group. So in other words, the people who got Hartman's, or when they got the Hartman's, they urinated this off faster. And that was shown here, where the time to first urination was over 3 hours on average when you got normal saline. So we're giving somebody this because we want them to pee if they're oliguric, but it takes 3 hours for the bolus to make urine in healthy people. And it only took 70 minutes for them to make urine on average when they got the Hartman's solution. So this started to be some sort of human data that sort of suggested that there's something about normal saline that might be affecting the kidney's ability to get rid of it. They came back several years later and repeated the same exact study design using plasmolite 148, which is the acidemic balanced crystalloid, OK? And I'm going to skip this, but again, you can see that the weights go up. And again, now the scales have changed. It wasn't a good idea on their publication. But now the solid line is the intervention of plasmolite. Their weights came down quicker again. So they reproduced the same data that the weights came down. And you can see that, again, the time to first urination was well over 2 hours, 2.5 hours with the normal saline, and about 90 minutes with the plasmolite. Now, since it was several years later, they actually put all these people in a functional MRI machine and measured several things during the bolus. And they showed that actually the change in renal cortical tissue perfusion during the bolus, that paradoxically, renal perfusion went down during the first 30 minutes of receiving the bolus, with normal saline, whereas it might have gone up, at best it stayed the same with plasma-lyte. And that's the same thing with the change in renal blood flow volume from baseline and the mean renal arterial flow velocity, that the flow through the renal arteries went down when patients got normal saline. So this sort of confirmed why the patients are having a harder time urinating, because the normal saline bolus is somehow causing renal artery vasoconstriction that is impairing kidney function. Now, this should come as no surprise, because in 1983, there were several animal studies which confirmed the same thing, that if you infuse different solutions into experimental kidneys and control kidneys on anesthetized animals, in this case dogs, you can see that the chloride-containing solutions all had a decrease in renal artery blood flow during the intervention period, whereas all the other fluids had an increase, or at least the same renal artery blood flow. So this just was further confirmation in humans that are confirming what has been seen in humans, that the dogs had demonstrated the same thing. Now, in 2004, in rats, we found that if you take rats and make them septic with like a fatal sepsis, or it's called cecal ligation and puncture, where they basically do a small surgery on the rats, they close off the cecum, and then they puncture the viscera so that they get abdominal sepsis. Unfortunately, all the rats will die. But when they infused them with LR, there was no change in blood pressure. But when they infused them with small quantities of very hyperchloremic solutions of two different strengths, as they gave them the hyperchloremic solutions, their blood pressure fell. And as chloride went up, so as the serum chloride went up, blood pressure went down pretty reliably. So this has been shown in non-cardiac surgery patients in a retrospective analysis of 22,000 patients. They found 5,000 of who became hyperchloremic after surgery, non-cardiac surgery, 22% of them. They case matched these with people who did not become hypochloremic, and they showed that as you become hypochloremic, your risk of death goes up after surgery, and even if you adjust for all sorts of different variables, that same relationship is still there. So now let's take this out and look more specifically at now some more sort of human trials, bigger retrospective studies, and maybe some prospective trials. So there was a big study, very important study done just a couple of years ago that looked at a retrospective database of major open abdominal surgeries. And they looked at people who only got balanced crystalloid on the day of surgery compared to people who got only normal saline on the day of surgery. They didn't want to have anybody sort of in the middle muddying the water. Okay? And they showed that this might be a little difficult to read, but if you look here, this is the side favoring balanced crystalloids, that there was a trend towards improvement in many different outcomes, with some of them reaching statistical significance, including mortality, gastrointestinal complications, renal complications. There was no change in cardiac, some respiratory issues, major infections postoperatively, and if you add all that together, the composite score did meet statistical significance. Furthermore, importantly, they showed that there was less blood transfusions, fewer ABGs, lower lactic acid level check, or fewer lactic acid level checks, and less frequent dialysis in patients who got treated with plasma-lyte alone on day of surgery compared to normal saline. And in the unadjusted group, there was a difference in mortality, but when you adjust for all these different potential comorbidities, that wasn't there. So there was subsequently a large prospective study done in Australia, which has now become a rather famous trial, where they took their entire ICU that was very big, and for 6 months they said you could only use solutions that are hyperchloremic solutions, so some of the albumins, some normal saline for volume resuscitation, and then they had a sort of exchange period, and then they said for the next 6 months you could only use balanced crystalloids, which had chloride-restricted fluids. And they had about 800 people in each group, and they showed that there was a trend that did reach statistical significance of a lower frequency of more severe renal failure. So in other words, fewer patients had more advanced renal failure. There was no difference in mortality, but there was a difference in, this is a difference in patients getting stage 2 or stage 3 acute kidney injury. So you can see it was more common during the normal saline time. And there was a small but important difference in the rate of dialysis that washed through in all of this. Okay? So we're getting several trials now that are starting to show that large volume resuscitation with normal saline might be not so beneficial for the kidneys. In 2014 in critical care medicine, there was a study, a very flawed study, but nonetheless with some interesting findings, that tried to quantify the percent of total fluid that was balanced crystalloid in the first 24 hours of someone's resuscitation for septic shock. And they showed that there's a pretty linear decrease, somewhat small, but still there, from about 22% to 16% for mortality in the hospitalization based on the amount of balanced fluid that they got. So the more balanced fluid they got in the first 24 hours compared to normal saline, the lower the rate of death in the hospital. And this held true if you looked at all the different quintiles. So if you just said 0%, 20%, 40%, 60%, in these quintiles, you can see that, that the in-hospital mortality rate was higher in the no balanced fluid group compared to the balanced fluid groups. We now are starting to have enough publications that are being published on this that there's starting to be some meta-analyses coming out. And I call your attention to this one that will be, it's not a typo, it's going to be published in January of this coming year. So they're already listing it as 2015. But this is all the trials that have looked at randomized controlled trials, other controlled trials, observational trials looking at mortality. It did not have the sepsis one I just showed you in here. And you can see that while it doesn't reach statistical significance, there's starting to be a little bit of a signal that maybe there's a difference in mortality. There's definitely seems to be a difference in renal failure rates favoring balanced crystalloids or the low chloride solutions. And there definitely seems to be a difference in blood transfusion rates in this group as well. So in conclusion, IV fluids are a medication. And, and they have a proper fluid that needs to be tailored to each patient. Hyperchloremic solutions appear to have detrimental effects on somatic and renal function, especially in large quantities, leading to more volume retention, more peripheral edema, increased severity of acute kidney injury, less vigorous urine output response, and a lower MAP, potentially, with worse survival. So I think that we really need to strongly consider the use of balanced crystalloids for large volume resuscitations in critically ill patients. I don't know if some of the other physicians that we'll hear from, or Dr. Gilmore, who's sitting back there, or others might agree to this, but I think for the most part, there has been a slow change in the paradigm that people are increasingly using balanced crystalloids. Those of you who are Grady, Plasmolite will be arriving sometime in, Plasmolite A, will be arriving probably in January. It's been all approved and we have to get it stocked. It is available on both of the other Emory campuses right now. I can't speak for some of the other sites that are listening into this broadcast. Okay, so how much fluid should we give? So let's change our practice now. Let's change our focus. We've done the first half. I hope we come to some agreement that balanced crystalloids are good, but you can tell me later what your own opinion is. So do we want to look like this, or do we want to look like this in the ICU? Or is it somewhere in between? Is more better? I think we've all seen this picture before. I think it's not rocket science to say that this patient is fluid overloaded. And I think most of us would look at this patient from the door and say something's not going well on this patient and might not go well in the days ahead based on this individual's massive volume overload. So if you turn back to these phases that we talked about of fluid management earlier, between rescue, optimization, stabilization, and de-escalation that I showed you that graph before, and think about it in a sort of table format. In the rescue setting, we're really in life-saving mode. Our main objective is to correct the shock, not to resolve the shock, but to get the patient into a hemodynamically stable state, even if they're on pressors and getting lots of fluid. This is really minutes crossing into hours, and it's really severe shock, and our goal is rapid boluses of expansion. Okay? This is what almost all of critical illness sort of encompasses these first two columns here. I should say all of critical illness research really encompasses these first two columns. The second one is optimization, which is more sort of organ rescue. We want to maintain tissue perfusion. We want to optimize it. We're not just accepting at this point 90/60. We want to make sure they've got a good SCVO2, that they might be starting to urinate, that we're seeing the lactic acid start to come down. And that really takes several hours. The patient's still pretty unstable. We're titrating fluids. We might be giving additional fluid challenges conservatively if we think the patient might benefit. Now, I will contend that whether your patient makes it out of the ICU has really not a lot to do with this. Even though we have this golden hour of trauma and this golden hour of resuscitation or golden 6 hours of early goal-directed therapy of sepsis, we've all gotten pretty good at doing this. What really decides whether your patient gets off the vent, whether they get better nutrition, whether they survive to get out of the ICU, really comes with the days and days of taking care of them once they get into the stabilization phase, okay? And I would argue that you don't really want that graph to continue to go up and up and up, that you need to level that all off. And others are starting to document in recommendations and in consensus statements that sort of philosophy. So in the stabilization mode, now we're sort of in organ support. We're keeping them on pressors. We might be doing dialysis. We're ventilating them. We're just sort of, they're sitting there for days and days waiting to get better, right? There should be zero or a negative fluid balance at this point. This can take many days. They're hemodynamically stable, but they can still be on pressors, okay? And there should be zero or minimal maintenance IV fluids. Remember, your infusions that they're on at this point is probably enough for their maintenance IV fluids, even if they're NPO. And then eventually, hopefully, we're getting to a de-escalation phase where things are starting to get better. Now we need to get rid of all this fluid because we want them to get off the ventilator. This can take days, sometimes many weeks. If you go to an LTAC, you still have very puffy people, but all the LTAC people will tell you that as soon as they get the fluid off, they get them off the ventilator. They're recovering, and we really need to avoid unnecessary IV fluids at this point, okay? In critical illness, we sort of have hemodynamics. So this is how you sort of come in, right? You've got, hopefully, normally, all of us sitting here right now, we have a certain amount of vascular space and we have a certain amount of blood and we're sort of in equilibrium. Then when we get critically ill, for one reason or other, you either bleed or you get vasodilation or something, but there is a difference between the amount of blood volume you have and the sort of potential space that it's in. And in our treatment options, we can give volume, or we can give to move the blood volume this direction, or we can give pressors to move the tank, to make the tank smaller, okay? And I would say that we've spent an awful lot of energy on this and not enough energy on this in general, and we'll talk about that as we go. So, because we spend so much energy on this, our patients are rather hypervolemic. So, as early as 1990, 40% of patients in SICUs had a greater than 10% increase in their body weight from pre-op or pre-morbid weight. So they came in weighing 70 kilos, and they now weigh more than 77 kilos. That was 40% of patients in 1990. What's the key about 1990? That's before anyone ever published any information about early goal-directed therapy of anything, okay? So I would venture to say that now this number is probably much more like 60 or 80. When I walk through SICUs, I see lots and lots of fluid overload. The mean total body weight and volumes generally increase in the ICU for at least the first 7 days unless you have a standard personal or unit-based approach to avoiding volume expansion. Okay? Let me show you. In the vasopressin and septic shock study, this was the daily cumulative fluid balance, or the daily fluid balance and the cumulative fluid balance. Over the 4 to 5 days in the hospital, you can see every day this patient was, the average was net positive every day for 4 days. And you can see their cumulative fluid balance just continued to go up and up and up for the first 4 days. Okay? In the FACT trial, which is a very famous trial we're going to talk more about ARDS and fluid management, there was 2 arms. There was a conservative approach or a usual/liberal approach to fluid. And in the usual group, over the course of the first 7 days, every day, the cumulative fluid balance went up. Okay? So unless you pay attention to this, your patients are going to continue to gain volume every single day. Now, is it detrimental that they're gaining this volume? What do you guys think? Yes or no? A lot of people don't know yet. Okay, so I'm going to start with some softballs here for you. If you have acute kidney injury, do you think it's bad if you get fluid overloaded? If your kidneys don't work? Is it easy to get fluid overloaded? Probably, because you're not peeing. And is it bad for you? Yes. Okay, so in these studies, they looked at defining fluid overload as this greater than 10% increase, okay? And you can see here that even if you compare not dialyzed patients to dialyzed patients, as they gain fluid, so this was sort of 0 to 10% gain, mortality wasn't very good, but as they stuffed up, mortality got worse, okay? And surprisingly, actually, if they lost weight by the time they had acute kidney injury diagnosis, they actually did better. And the odds ratio for death, if you were fluid overloaded at the time your dialysis was initiated, was 2 times higher. How many of your patients are fluid overloaded when they reach dialysis in the ICU? Like 100% of them? You'll actually find, I've actually found that because I pay so much attention to their fluid status, I have a lot fewer patients actually getting to dialysis. So who knows what these numbers are, you know, if people pay attention. But generally speaking, every person ends up being fluid overloaded by the time they get to dialysis, and we're already doubling their risk of death. So that would argue that maybe we need to start dialysis earlier, maybe we need to be more aggressive up front, the ICU teams need to be more aggressive when nephrology hasn't even been involved yet. The interesting thing also is that if you look at the people who are on dialysis alone, and now look at the percentage of dialysis days that they met that definition for fluid overload, there was a very clear relationship between more dialysis days that they were fluid overloaded, the more risk of death. So if someone is fluid overloaded, you really want to try to get them to get the fluid off with dialysis as soon as possible, because that would suggest that these patients are going to have a better chance of surviving the hospitalization. Hypervolemia also predicts death and sepsis. So there's a very strong association between a positive fluid balance and adverse outcomes in septic shock. Okay? Some studies say that every 1 liter increase in cumulative fluid increases your risk of death by 10%. The vasopressin study that we already talked about, these are very hard pictures to see, but the groups that had the most fluid, which are these 2 bottom groups, had a much lower survival rate, whether it was in the first 12 hours or in the first 4 days. If they got more fluid, they had a lower rate of survival. And this is adjusting and correcting for severity of illness. Okay? So when you do all these retrospective studies, the big thing that you have to pay attention to at some degree is whether the association holds true after you correct for various severities of illness, because the more severe people might get more fluid. And in this study, when you do that, it does hold true. In ARDS, we know that volume overload is an independent predictor of death, and that weight loss and lower cumulative fluid balance over 14 days was associated with improved survival, and that in the SOAP study, they also showed that the odds ratio for death in patients with a positive fluid balance was about 1.5 times above. Which group in this group of acute lung injury patients with septic shock now survived, and which ones did not? The survivors were able to taper off on their fluid balance. And this study did one other very important thing, which I cannot stress enough. They broke down patients as to whether their initial resuscitation was adequate in these first 2 bars versus inadequate. And they defined that by a certain amount of fluid, like I think it was 40 mLs per kilo in the first few hours. Okay? So like whether did they get some sort of expansion on admission or not? And then they broke down patients as to whether or not they had a conservative or liberal fluid management after the initial resuscitation. And to meet the conservative, to get to be awarded yourself as having been conservative, you only had to have an even to net negative fluid balance on 2 consecutive days, sometime in your first week in the ICU. So it's not a very hard bar to cross there if people are paying attention. And you can see that it's no surprise that if you didn't get resuscitated very well, you had a worse mortality than if you got resuscitated, okay? So this bar is better than this bar, and this bar is better than this bar. However, the interesting thing is that there is a very strong association between liberal fluid and conservative fluids, such that even if you got adequately resuscitated but liberal fluids, you were much more likely to die than the person who had a terrible doctor when they first came in the hospital, but then had conservative approaches to fluid afterwards, which would sort of suggest that it's not all what we do up front that makes a difference. It's what we do days 2 through 7 that makes a huge difference in our patients' outcomes. I'm going to skip this for a second. Okay, this even holds true in trauma. So if you look at adult blunt trauma patients and look at their ED resuscitation, the more crystalloids they get, the more the risk of acute lung injury, multi-organ failure, surgical site infections, abdominal compartment syndrome. It also holds true for ICU and hospital length of stay, vent days, bloodstream infections, and the such. So lots of bad things that happen are strongly associated with the amount of fluid that you get in your initial resuscitation. Now, the trauma doctors who aren't here today will say, well, this is why we shouldn't be giving any of these patients crystalloid. We should be giving them all blood and FFP, right? And that's a very well and legitimate reason to read this, but there's also probably something to do with hypervolemia in here as well. And for the surgeons that are out there or listening, I also get a lot of questions about, well, I'd rather have my patient fluid overloaded than on pressors if they have like bowel anastomoses. There was an animal model done where they looked at patients getting, animals that got a partial small bowel resection in primary anastomosis. And they either had sort of a medium amount of fluid, which was the sort of control group. They had a low amount of fluid in the surgery, which was the minus, and after surgery, which was the V negative group. And they had a lot of fluid in the V positive group. And what they showed is that the pressure needed inside the intestines to burst the anastomosis was a lot lower in the fluid overloaded rats, or what were these, rats, than in the fluid restricted rats. And this here is hydroxyproline measurements. This is a measure of collagen formation. So how well is the wound healing with collagen formation was a lot lower in the fluid overloaded groups. And you can see in these micrographs, you see this little very thin, clear rim that's going around here underneath the mucosa and on top of the muscle. This is fluid that's accumulating sort of in the subcutaneous areas and potentially is at risk for sort of breakdown of the anastomosis. So all the concern that we sometimes hear that maybe pressors are bad for the anastomosis, it looks like fluids are potentially bad for the anastomosis as well. And then finally, intra-abdominal hypertension and abdominal compartment syndrome is a well-known complication of fluid overload. And I'm just going to briefly review this because many of you haven't seen this before. But intra-abdominal hypertension is defined as a intra-abdominal pressure greater than or equal to 12. Abdominal compartment syndrome is greater than or equal to 20 with some new end organ dysfunction, which I can tell you is like 90% of the time they're not urinating or their creatinine's going up. And we measure this by bladder pressure. And just for the naysayers out there, this is all the studies that have been published through 2009 looking at the frequency of intra-abdominal hypertension and compartment syndrome in various different ICUs. And you can see that anywhere from 20 to 60 to 80% of patients at any one time in the ICU suffer from intra-abdominal hypertension as a result of their fluid expansion, with somewhere between 5 and 20% having true abdominal compartment syndrome, meaning greater than 20 and a new end organ dysfunction. Okay? Now, this I find is very interesting, and it's also a terrible indictment on us as critical care because we spend a lot of time focused on bloodstream infections and CAUTIs, which should be pretty rare, right? And we have something that's affecting, at best, maybe 50% of our patients in the ICU, which most of us have very little knowledge that's even going on, and continue to have debates about whether or not it really even exists. So when intra-abdominal pressure goes up, there's a whole host of effects on the body. None of these are particularly good. So as pressure in the belly goes up, it pushes up on the lungs, making it difficult to breathe, making your ventilation go down and your oxygenation go down, your PaO2 and your PCO2 go up. You get more dead space, you get more intrathoracic pressure, it's hard to move the diaphragm down or to breathe. You also get a lot of cardiac effects with increasing CVP and decreasing cardiac output. You get increased ICP. Jane, I did throw something in there for you after all. Okay, and you also get splanchnic problems here, because if you have increased intra-abdominal pressures, you might not be perfusing your viscera very well, which causes more edema and translocation and of bacteria and cytokine release, and it just is this vicious cycle, making all of this even worse. And then your kidneys sit way back here underneath this flap of omentum that they have right here. And when you get increased intra-abdominal pressures, you get lower arterial perfusion, you get venous congestion, so that the blood can't drain out of the kidney. If the blood can't drain out of the kidney, new blood can't come into the kidney, and so GFR starts to go down. You get oliguric, you get diuretic resistance. This is a big problem. How many of your patients are oliguric and diuretic resistant? If you look at them, I promise you, if you check bladder pressures on those, a good 30 to 50% of them are going to have high bladder pressures, and all you need to do is raise their MAP targets, and they'll start making urine. So intra-abdominal hypertension greater than 15 can definitely cause significant end organ dysfunction. Abdominal perfusion pressure is the same as cerebral perfusion pressure. You need it to be greater than 60, and instead of MAP minus cerebral pressure, or intracranial pressure, it's MAP minus intra-abdominal pressure, and you want that number to be greater than 60. And the presence of intra-abdominal hypertension is very consistently associated with high ICU mortality, and in fact, an inability to maintain an abdominal perfusion pressure greater than 60 by day 3 of hospitalization really strongly predicts ICU mortality, even better so than things that we've been working on for years, like lactate clearance and other sorts of things like that. Okay, so now we've talked about, I hopefully have convinced you that volume overload is probably not a good thing. That at least at best, whether or not it's causing problems, it's certainly associated with a lot of problems. So the question becomes, if we control volume, do patients get better? So the FACT trial, which I alluded to before, was a randomized controlled trial of 1,000 adults with acute lung injury that wanted to look at conservative liberal fluids versus more conservative fluid management, ARDS, and see if patients did any better. The primary endpoint was 60-day mortality. The trial was not powered well enough to look at that primary endpoint, in which you'll see in a second. And just so you see here, they either had a CVP or they had a pulmonary artery catheter, and their goals were really quite low on wedge pressures and CVPs. They did not attain these goals. But despite not attaining these goals, there was a striking difference between the two groups, between total body, length of stay fluid balance, okay? Such that by about day 3, the conservative group had reached euvolemia again. This is despite the fact that shock or hemodynamic instability was occurring equally in both of these two groups and was present about 80% of the time. And while there was a trend towards improvement in death, it, again, was not powered well enough to show this. There was definitely an improvement in the length of time on the ventilator. Now, this is challenging. This is ventilator-free days. So here, a higher number is good. And the conservative group had 2.5 fewer days on the ventilator in the first 28 days and fewer days in the ICU in the conservative approach. And this is despite the fact that there was really no difference in mean arterial pressure in these two groups, and there was really no significant difference in creatinine. This creatinine in the conservative group is a little bit higher. There was no difference in mortality. Now, I will tell you that they're taking fluid away here, right? And creatinine concentration is somewhat related to your total body fluid status. So as a patient gets dried out, you would expect their creatinine to sort of go up a little bit. That has nothing to do with renal function, has more to do with a heme concentrating mechanism. So it doesn't appear to cause more kidney injury. This has also been looked at in surgery. So in elective colorectal surgery, they took people prospectively and said, let's do restricted fluids versus standard fluids. And they can see here that the weight changes were much lower in the restricted fluid group, and the overall complication rate was much lower in the restricted fluid group, including tissue wound healing complications, minor infections, cardiopulmonary complications in the restricted fluid group. And there was this very similar rate of hypotension. There was a little bit more oliguria in the restricted fluid group. The creatinine measurements were about the same. This is not our usual measurement. This is millimoles per liter. You divide this by 88, and you get to our normal one. So both creatinines were less than 1. And in coronary artery bypass grafting, this has also been shown as well in a retrospective study looking at conservative versus liberal. Look at these cut points. I've never seen somebody come out. I do cardiac surgery half the year. I've never seen someone come out of the operating room with less than 500 mLs of total body fluid balance. But there was a pretty striking difference need for things like balloon pumps and other sorts of complications, including ICU readmission, ICU length of stay, hospital length of stay, and what's this other one? Renal complications in the groups that had conservative approaches to fluid in cardiac bypass. So I think in general, we are starting to get more and more data that suggests that if we are conservative with fluids, that we now are having actual prospective studies showing that the patient's outcomes are better. Okay? That's whether we are conservative up front or conservative after the fact, like taking fluids away. I'm going to skip that and come back to that in a second. Okay, so to finish up here, let's talk about how we're going to put this all together and manage these patients' fluids and deal with hypervolemia. So do you have a power cord? Because we're about to run out of battery over here. So returning to this, we've got a lot of emphasis on expanding A. Maybe we need to talk about the emphasis on vasopressors. So I would argue that we have a little bit of a fear of vasopressors. I will admit that I've, in the past, had a big fear of vasopressors as a resident, and that has subsequently completely disappeared. We have some complications from vasopressors, or at least we have a fear of some complications for vasopressors, and this includes some fear of ischemia, of some wound healing. I already mentioned some of this anastomotic connection fear that we have. Of course, the pressors need a central line, so there might be some complications related to the central line placement. In most of our skilled hands, hopefully we're not dropping lungs too often. I don't know about some of our NP or PA residents or some of our other residents, but in the attending hands, I haven't had one in several years, so knock on wood that continues. So I just wanted to show you that in anesthetized pigs that were hypotension from anesthesia, they wanted to measure the effects of pressors on visceral blood flow, because there's always been this concern that if you push people's maps up with pressors, that the visceral blood flow will go down. And they actually showed that renal blood flow, if you follow across here, was no different with pressors, and that renal delivery of oxygen was no different with pressors, and that renal vein lactic acid was no different with pressors, and the same thing with mesenteric delivery of oxygen and mesenteric artery or mesenteric vein lactic acid measurements, as well as some other measures of hemodynamic status, that there was basically no difference. As you pushed these pigs' maps up higher and higher with pressors, they still perfused everything. And there's been this idea that maybe the pressors are causing ischemia or other sorts of stuff like that. Now, that doesn't mean that it can't occur, but I would argue that if you're seeing ischemia, it's probably because you're on pressors and the patients are volume depleted and they're not getting appropriate perfusion. Or their heart sucks and they need inotropes. Okay, so fluid management. So I would argue that we need to really think very strongly about avoiding excessive IV fluid administration. We need to avoid hypervolemia. We need to move away from the idea of maintenance fluids on everybody. They're more than getting enough in their drips and their nutrition. We should bolus if they're depleted. I would continue to argue for a goal-directed volume expansion in resuscitation and optimization phases of shock only, and continue to assess whether they're fluid responsive. Convert them to a conservative approach to fluid as soon as possible, and that the third spacing, this phantom third spacing we all hear about, is probably much less than estimated. So who's nurses in the group? How many nurses do we have here? Okay. How many times do you guys have a patient with an open abdomen that has a wound vac in place? Now, the surgeons always tell me that their patients need 150 mLs per hour of LR for the first 3 days after surgery because they're going to be third spacing a ton into their abdomen. I've never seen 150 mLs an hour coming out of a wound vac on an open abdomen, ever, unless they're bleeding to death, at which point then it's blood and we have a whole different problem, right? So we generally grossly really overestimate this process of sort of third spacing. It's very hard to quantify, but there's lots of studies that are suggesting now that we're overestimating this. I would argue you need to have a liberal use of vasopressors, especially if they're not fluid responsive. If they're not fluid responsive, don't continue to give them fluids. I think, well, not just me, there are many clinical guidelines now, certainly in sepsis, in trauma, in surgery, I think also in neurosurgery and neurology, central nervous system issues, that all support the use of vasopressors as primary modes of hemodynamic support. And the MAP targets really should be adjusted if there's a history of significant premorbid hypertension or intra-abdominal hypertension. Norepinephrine and to some extent dopamine are really the recommended first-line agents. I don't think there should be any controversy with that. If anyone wants to argue with me on that, feel free. There's unequivocally no benefit of renal dose dopamine. I hope almost nobody is doing that anymore because that's actually been shown to be somewhat nephrotoxic. We don't really know what vasopressin does. You might have noticed in the surviving sepsis guidelines, they very much have de-emphasized the use of vasopressin, and it's largely because we're not really sure if it's actually providing any real hemodynamic benefit. We all still do it anyway. It's always curious to me why we don't see patients not make urine when we're infusing antidiuretic hormone into them. And we should use inotropes, especially if there's any concern about cardiac stuff. Let me just show you here. This is role-directed therapy in surgery. So all of us that do sepsis, there's also a whole bunch of literature about patients having big surgeries, how do we take care of them in the operating room, and right away after they come out of the operating room. Okay? And you can see here they divided into four groups. This is no greater fluid administration. No inotropes. So they got some sort of therapy, but they did not give them lots of fluids. And it sort of favored pain and having goal-directed therapy. Now here they gave inotropes with no extra fluid, and there was strong improvement in renal outcomes or other outcomes favoring goal-directed therapy. And then these two bottom ones, goal-directed therapy, included more fluids and no inotropes, or fluids and inotropes. And you can see that it's really the inotropes that are deciding whether patients have favorable benefit of goal-directed therapy. So there is more to come on this. The fluids might not be what helps the additional cardiac output that helps. Whether that's inotrope-driven or fluid-driven is something we have to look out for. Okay. So to finish up here, management of hypervolemia. So what are you going to do once the patient has become hypervolemic? So I would argue if they have symptomatic hypervolemia, you need to take away volume safely. Symptomatic hypervolemia is you can't wean them off the ventilator, even if they're on minimal FiO2, if they are failing SVTs and they are anasarchic, they are symptomatically volume overloaded. Their chest wall is too stiff from fluid, their diaphragm can't move. Okay? Intra-abdominal hypertension is a form of symptomatic volume overload. Okay? If they have symptomatic volume overload, you should take volume away. Albeit safely, but you should do it. And I would argue for either, well, we really only have two options. I didn't put diarrhea on here. Diuretics or extracorporeal volume removal. So with diuretics, we have loops, bolus loops, bolus Lasix infusions. We have not yet done a very good job studying combination therapies versus loops. But I will tell you that there is some studies and lots of anecdotal evidence, my own personal evidence, that if you use combination thiazides and loops, even in low doses, you're going to be much more effective at causing diuresis. And more importantly, what are these people fluid overloaded with? They're fluid overloaded with high salt-containing solutions, right? So you don't want them to pee out hypotonic urine. You don't want them to pee out clear urine that doesn't have any salt in it. You want them to pee out salt and water. Because if they just pee out the water, then they all become hypernatremic and you're giving them free water back, right? So using combination therapy, if you actually look at the random urine sodium levels when someone's getting both thiazides and loops, they tend to have a much higher sodium content in the urine, and the urine is much more sort of like isotonic saline in its composition. And then I'm a big believer in dialysis. We'll talk about that in a second. And I would say that pressor use is definitely not a contraindication of fluid removal, but it depends what area of the phases you're in. If you're in this resuscitation and optimization phase, you're still trying to catch up. That's not the time to be taking away fluid if they're on norepi. But if you're just sitting in the stabilization phase or the de-escalation phase where the pressors are getting a little bit better, you feel safe that the data is pretty consistent that you can safely feed a patient, for example, on pressors in that situation, then it's safe to take fluid away too. Now, you're certainly going to watch and make sure that things don't go crazy, but I frequently will use pressors and keep the patient on pressors to facilitate them diuresing. Because if they diurese and get off the ventilator, they're going to be a lot better off than if they're stuck on the ventilator but off pressors, right? Okay. And just the one final point I want to make is that there are several studies which are consistent that intermittent hemodialysis leads to an inability to control volume, and that CRRT predictably has improved fluid balance control over time. So if the patient is hypervolemic and they're on CRRT, we as the intensivists need to encourage the nephrologists to not transition to intermittent hemo until either the patient's ready to leave the ICU or they're euvolemic. Because if you transition with them still hypervolemic, even if their blood pressure is great, the data would support that you're not going to get their volume under control, okay? At least in the garden variety intermittent hemodialysis. All right, so for conclusions here, is it time to abandon sodium chloride? I would say that balanced crystalloids, I think, provide superior outcomes compared to normal saline for large volume resuscitations, and I would say the answer to that is yes. Is it time to abandon hypervolemia as standard for everybody, defined as a greater than 10% fluid goal? It is very common, and it's strongly associated with bad outcomes, and conservative approaches to fluid management seem to lead to improved outcomes. So I think the answer here is yes. And I think in that situation, I have to be willing to accept vasopressors. I think they're safe. There's really no data that we have in humans that show that vasopressors are not safe. So regardless of what everyone argues, norepinephrine and epinephrine have been definitively shown to largely be safe with really no significant side effects. I think that might not be true for phenylephrine, but certainly for our usual dopamine, norepinephrine, or epinephrine, they are safe. And I am a strong believer in the liberal use, especially during the optimization and stabilization phases. And then, whoops, sorry. And then I would urge you to have volume removal whenever the patient is symptomatically overloaded. Now, I will tell you, remember when we started this talk, I told you that my clinical practice has changed a lot. So this is all subjective information, but before I was very much sort of like, well, they're swollen, they'll get better eventually. I tried to focus on getting people off pressors as soon as possible, even if I had to volume expand them some more. And as a good nephrologist, you know, I always thought that wet was better, even though now I've thankfully learned otherwise. And I have, over the course of the last 3 years, really migrated my practice to one that focuses on balanced crystalloids, firstly, and also to really, really tightly controlling fluid. I start diuresing people very early. Marina will probably tell you that sometimes she thinks I'm a little bit crazy in the MICU with how early I start diuresing patients, but I start diuresing them very early. And I can tell you that subjectively, I have definitely seen improvements in my clinical outcomes during this time. A lot less patients getting trachs, a lot less patients going to LTACs, a lot less dialysis needs and the such. So I think that once we get the studies, I think that people will see that there is beneficial. And I urge you to at least think about maybe changing some of this in your clinical practice if you haven't done so already. You can now throw your tomatoes and your arrows. If you have any questions, contact me, and I'm happy to take any questions or hear any strong opinions. Thank you. Yes?
I have a question that's actually not
It's a good question. We don't have any studies on this yet. I'm a big believer in evidence-based medicine. So the question that was asked was, what do we think about routine monitoring of bladder pressures in patients who have Foley's? There's no studies on this yet. I think that there are studies that need to be done, and they're easy to do, as to whether or not if we monitor these and we control blood pressure and abdominal perfusion pressure in a systematic fashion, do patients have better outcomes? These are studies that are right for pilot studies, for trainees and fellows and others to be doing, and to be thinking about larger trials. I definitely encourage people to do that. But I don't think the data is there yet to support routine use in everybody. I tend to order it if I see a patient who's on pressors, who we're targeting a MAP of like 65, and suddenly they're not making much urine, and we look at their urine electrolytes and they suggest that they're sort of pre-renal. The first question I'm going to ask is, what is their bladder pressure? And if their bladder pressure is high, then we start going for a higher MAP, and almost always they start making urine and we're out of the situation. Great question. Yes? Great question. So the question is LR versus plasma light. We have no studies on that yet. So I can't tell you. Cost-wise, they're about the same. So Grady cost is $1.50 a liter for LR and $2.50 a liter for plasma light that we're going to start to get. So I think you can use it as you wish. We've been using a lot of plasma light in our post-cardiac surgery ICU at the Clifton campus, and we're not just me. Globally, people are quite happy with it. We certainly have less acidemia issues and less blood gases because of the neutral pH. If anything, they're mostly alkalotic when there's as a side effect more than acidotic. But there's no studies on that. You should do it. We need a third arm though too, which is normal saline.
A couple of questions I could find out.
Yeah.
In terms of with resuscitation, like you said, one of the challenges is you want to wait till they're out of that stabilization phase to start the diuretic initiation or any kind of diuretic initiation.
Yeah, optimization really is probably the second phase. You want to probably be out of that second phase. Yeah.
So my question is, because it's happening in trauma, how do you know when you're out of that phase? Like when is that phase? Do we get symptomatic for the ALI or ARDS even in those phases? So in theory, it's physiologically, even if you diurese them, they're going to have leaky capillaries because of the disease process itself.
Right. So the question is, how do you know when you're out of the rescue, resuscitation, and optimization phase? It's not cut and dry. It's not black and white. It's very difficult to sort of know that. But I think with practice, if you pay attention, I sort of say, look, if I'm at a stage where the pressors are now sort of stabilizing, I'm not escalating, I always look, how much work is the nurse doing? When the nurse workload goes down, that's generally a good sign that the patient has sort of reached some sort of homeostasis, okay? The number of orders that I'm having to enter falls off a cliff, then you generally have reached sort of a stabilization phase. Lactate, when lactates are going down, SCVO2s are sort of okay. Then I think we overestimate this amount of sort of capillary leak. And in fact, there's increasing studies that suggest that volume overload actually causes the capillary leak because it degrades the glycocalyx of the capillaries and makes the capillaries more leaky. So now that doesn't mean that taking it away is going to protect the glycocalyx because the damage is already done, but sort of recognizing that our goal is really not to make the patients hypervolemic, it's to make them euvolemic so that they have enough cardiac output and filling volumes and then sort of go from there. Okay? And I always argue that you're in an intensive care unit here. You've got more monitoring than we know more about the patients, than almost anywhere else in the hospital in general. You should be able to know that your patient is becoming volume depleted by your monitors, and it shouldn't be a subtle issue. Their urine output isn't good, their cardiac output seems worse, their lactate is going up. Something should be cluing it off long before, and preventing it by some maintenance, sort of issue is not going to help the situation. Your other question.
My other question is related to pressure. So I know this is not great data, but we stated from the late 80s, early 90s, suggest that especially looking at sepsis, which is from what you presented here. There's some physiologic changes that you can get. Obviously, I've looked at mesenteric ischemia, and pressures do increase ischemia, particularly dopamine and epinephrine in the mesenteric, and sepsis per se. So, based on what you presented was anesthetized dogs who are not septic, and so that physiology is completely different. So,
absolutely.
So
the question
is as safe as you say they are in sepsis versus in non-septic population.
So the question is, are pressors as safe in sepsis as I make them out to be? I still challenge you the problem with the 70s, 80s, early 90s is that it really honestly, even though it does for those of us that are getting a little bit older, doesn't seem that long ago, okay? It's really a completely different era in terms of how patients were cared for. And there was no systematic ways of sort of volume expansion and goals of which we were trying to sort of attain, as sort of was heralded by the whole Manny River stuff and all sorts of trials that have come since then. I really challenge you to actually find a trial that shows increased risk of major complications like ischemia from liberal pressor use in the modern era. You're not going to find them. And even the trials going back in the past in sepsis, they're not great. I mean, for all that people quote as being these horrible effects of pressors, they're not. It's not as great. The effect size was not as great as people say. And I think we've passed this along as dogma for a long time, right, Jane? We've passed this along as dogma, which I don't think is necessarily right. Other question? Yes, Jane. I think so. The question is balanced crystalloids in the setting of neurologic injury and high ICP. I can't argue with that. I think that, remember that the plasmolyte's osmolarity is 294, normal saline is 308. You're not going to have too much difference there between plasmolyte. But yes, with LR, you probably will have a little bit. I'd venture to say that even if you're using your normal saline, most of your hyperchloremic metabolic acidosis issues are coming from your 23.4% boluses. Would you agree? And regardless of what solution you're using with that, your 23.4 is going to blow it out of the water, so you're sort of going to lose all stuff. And I can't argue with that, absolutely. But it'd be an interesting study to do with ICP monitoring, wouldn't it? Because you certainly get less edema formation, or at least peripherally, so you might get less brain edema formation with balanced crystalloids, and that would be an interesting thing to look at. You might be surprised. I don't know, for the good or for the bad. Well, thank you so much for the invitation. I'm sorry, it's a little bit late at night, so I didn't have my usual jokes all lined up, so I apologize about that. I'm glad that everyone stayed awake, but I think that was largely because they're trying to get a gift card. But thank you.
Thank you so much. And as tradition has it, the speaker gets to